Hello, Louisville. Guess who's coming to dinner? Well, hello there. I'm back. Took a little vacation, needed a break. After being in the house for seemed like 2 years, or not being on a plane for 2 years was really kind of different with the mask on the whole way. But we went to the wine country, a place called Paso Roble. So I had to give my hometown a break and re-energize my brain and get ready for everything that's coming up new. And the news is always the news and exciting. And today I have a very interesting and one of those individuals that knows what we should know and maybe has some information that he might want to share with us. His name is Mr. John Chenault. I call him Professor John Chenault. He's an associate professor at U of L. Welcome.
Good evening.
How are you, darling?
I'm doing well.
Wonderful.
How are you doing?
Well, just settling back down. I had a nice little break. Last time we were together, we were on a Zoom.
Yeah.
For the Kentucky Center for African American Heritage board meeting. And that was my first meeting, our first encounter. And found out that we might be relatives. We have to research some of that, huh?
I wouldn't be surprised. It's a small world, actually. And
and when you get that small into a certain area of Kentucky, now
yes.
That's small.
Not only that, but Kentucky's African American population is quite small,
Right.
Comparatively speaking. I moved here from Atlanta.
Okay.
And Atlanta has as many people or more than the entire state of Kentucky.
Absolutely.
So that puts it in perspective. So, when I came here, the majority of Black people in Kentucky live in Louisville.
Right.
And, you get a false impression about the state because of that, I think.
Right.
Yeah.
They don't know. They keep, they call me up when it's election time and said, so what's the problem? How did you all become a red state? I said, we've always been a red state. Yeah. You can count, like you said, you can count us on one hand for the whole state compared to populations in other major cities. The largest population is Louisville and Lexington.
Yeah.
And then you put us all together, we might make up the population of what, Indianapolis?
That might be true.
Oh.
Yeah.
About that.
That's a good approximation, I think.
It seems like we're kind of close to that. But you have a very interesting position. And I don't know if I mentioned when we were on the Zoom before that I am a part of the book study with Nubia Bennett,
Okay.
Anti-Racism, how to become anti-racist, by Ibram Kendi. So I thought I would get involved with that. I said, since I'm having a show that's having a conversation about racism and racist policies, maybe I should go a little deeper than what I think I know. You know what I'm saying? So explain your position. What do you do? What does your position entail at U of L?
So a year ago, the School of Medicine at University of Louisville, last summer, in fact, I think around June last year, so it's been about exactly a year, it developed what they called at that time an anti-racism task force.
Okay.
And the purpose of it was to deal with the fact that medicine is operating on a basis of racial medicine. It's race-based.
Okay.
There's been a history of medical professionals trying to racialize diseases, and it begins in the era of slavery. Okay. And part of the reason for that is to rationalize and justify enslavement by saying that African Americans are physiologically and mentally inferior to Europeans.
Mm-hmm.
So the architects of that are, in many cases, are physicians, and so this permeates medical education, medical research, and medical practice.
Mm-hmm.
And just this year, finally, the AMA has come out and agreed and has also developed some guidelines that it is using to direct medical schools across the country to dismantle systemic racism from
Wow.
instruction and curriculum. So my job is basically to help in that process at the University of Louisville School of Medicine, working with faculty, students, and staff to examine our practices and our
Mm-hmm.
curriculum and to revise them accordingly
Mm-hmm.
so that we no longer perpetuate what is a history of medical folklore that
Mm-hmm.
Black people have thicker skins, age differently, are
Right.
susceptible to certain diseases and more susceptible to others. There's a whole host of these things that
Wow.
exist today. Some formally that are still in instruction, and some that are informal that are basically word of mouth, the kind of things that happen when older physicians are teaching younger physicians in the hospital while making rounds. They may drop a line or two, which they think is based on their experience, but is really grounded in mythology. So a tremendous amount of work is going on across the country in medical schools around this issue. We're not by any means alone in doing this. This is a national movement. As I said, AMA has finally gotten on board. 80% of the members voted in favor of doing this. There's still a large segment of the physician population that resists these changes. And like many others in society, a certain segment view them as ideological and political.
Mm-hmm. Mm-hmm.
Our entire approach to this is that anti-racism is good science. It is medical science to be anti-racist. To operate on the basis that there are biological differences between human beings that arise to a level of some kind of racial difference or racial group is
Mm-hmm.
absurd. It is absurd. There's no biological way of grouping people into a permanent and fixed group. And you know, and we all know, when you look around in our own families,
Right.
they are diverse to the core.
Yes,
Every
sir.
skin color, hair texture, eye color you ever want to see. And that's true for the entire family of humanity.
Okay.
So we cannot be grouped into these categories. There's no way in the world that you can say all Black people have this genetic characteristic
Right.
and no white people have that genetic characteristic. There's no such thing on the planet that distinguishes any person from any other person in that categorical way. We
Okay.
are all different
Right.
down to the level of the individual, not different as groups. And that's the biggest thing that we have to get across in our society. And it's certainly what we're moving towards in medical education right now.
Well, that's an extreme. It would seem like it's an extreme approach that we have to take just to get to the truth. You know what I'm saying?
Yeah.
For, like you said, for some older physicians to use off the cuff myths that they heard or something that they grew up saying or that they were taught, like most of them are. They're taught these things, and they're not truths. Just like now, we're having to decipher truth from a lie
Every day.
every day.
Every day.
Break it down one time for me, So to go through
Let
that
me give
thing,
you.
go on.
I want to give you an example of what
Okay.
I'm talking about in terms of what happens in medical training. So about 3 or 4 years ago, an article came out. It was a study that was done at the University of Virginia Medical School. And what they were looking at, they were trying to determine, it was all geared towards under-medicating and under-prescribing pain medication for African Americans. And they wanted to survey medical students and residents about their perception of African Americans' experience of pain. And not only that, they looked at the other issues I mentioned about aging and whether the skin was thicker and all that. And it was amazing how large a percentage of both students and residents, people that already graduated from med school, believed in those myths, right?
Oh,
Now,
wow.
the importance of that particular study, it wasn't connected to what I'm getting ready to tell you, but here's how this all comes together. So what this study found, and this is true, that typically African Americans' pain management is really poor because physicians, particularly white physicians, refuse to prescribe pain medication or refuse to adequately treat the pain of African Americans, partly due to some kinds of stereotypes about drug behavior or drug seeking behavior, whatever the reason. We have been significantly undertreated, undermedicated, under anesthetized, or under pain managed, inadequate pain management, as however you want to describe it. This is how significant the problem is. A study was done last year which showed that because white physicians would not prescribe pain medication at the same levels that they did for their white patients, about 20 to 30,000 African Americans lived through the opioid crisis, did not overdose because they were not addicted to pain medication by their, given those pain medications by their doctors. 20 to 30,000 Black lives were saved because of racism in prescribing pain medication. That's how significant these problems are, right?
So they had no idea that they were saving us, did they?
No. It was just a paradox, that's how it came out.
Right.
So that worked in our favor. It didn't work in the favor of those people that were suffering from pain.
Right.
Obviously, they obviously needed to be cared for. But in the extreme cases, it actually saved lives.
Saved lives. Wow.
Let me mention one other thing that is so common in medicine every single day, and that is completely racial nonsense. And that's called racial correction algorithms and diagnostic tools. So, because of the history of believing that Black people have different physiology or different metabolisms, et cetera, and this goes back to Thomas Jefferson's day, where they actually argued that Africans' respiratory systems were inferior to white people. In fact, all other people in the world have, by this concept, an inferior ability to breathe, to inhale and exhale, that our lung capacity, et cetera, is deficient, right?
Okay.
Because of this, when a device was invented in the 1800s, mid 1800s, called a spirometer, it's a device that you breathe in and it measures your lung capacity.
Okay, right. Okay.
That device was created and then calibrated according to a racial correction setting to correct for the deficiency of Black people, so that when you use a device, you use a special setting for Black people because their lung capacity and efficiency is not as good as white people. This still exists today.
Get out of here.
There's race correction for African Americans. There's one for what they call the Mexican American one, which they use for all Latinos, and there's an Asian one. Now, when they started putting the Asian one together, they didn't have a lot of data on Asian people, so they kind of manufactured what they came up with. They kind of cobbled it together. So to this day, this device is used and racially corrected. Another one that's very commonly used, and you only encounter generally when you're a patient in a hospital, is called pulse oximetry. That's a little device that when you're in the hospital, they put on the tip of your finger.
Okay.
And it's measuring your oxygen saturation, how much oxygen you're getting into your system. Mm-hmm. Well, a study came out a few months ago that shows pigmentation affects that ability for that device to register correctly. And that there are many cases where African Americans are not getting the correct readouts in terms of their oxygen levels, which could be extremely dangerous, given if they're in some type of significant problem in the hospital. So that's another one. There's a third that has to deal with kidney markers or biomarkers for kidney disease.
Hold up on the kidney so I don't lose my thought.
Okay.
So you're saying they made up one for the Asians.
Oh yeah, sure.
But
All
it
of them
sounds like they had to make them up for everybody.
every one of them is made up. There's no validity to any of them. But I'm saying that at least with African Americans and the Latinos, when they started putting them together, they had a lot of hospital data records, a lot of medical information, which they didn't have on the Asian population when they started putting this together. So that's when they kind of improvised it a little bit. But all of it is improvised and made up. None of it makes any sense. And listen, let me say the thing about the spirometer, the cure for that, as far as Thomas Jefferson was concerned, was to put black people out in the field and make them work all day. That was going to be the thing that helped them heal their lungs or improve their lung capacity.
Oh, they build up stamina.
Yes.
Get out of here.
Right. So, it wasn't like it was an outlet for African Americans to get some kind of relief from work. No, it was the exact opposite, obviously.
Oh, merciful. That is just horrendous to me. And like you said, it was still going on until some of these studies came out.
No, it's still going on. It's still going on.
Okay, but this is a part of your job.
Spirometers are used every day. Pulse oximetry is used every day. The kidney marker is used every day. These things still exist. I see articles.
Tell me about the kidney marker.
So there's when you get your analysis, your blood work, there's a marker that they look for that has to do with creatinine levels in your system, and it indicates when you're having problems with your kidney function.
Okay.
And if it goes to a certain level, a person will need to have dialysis. The marker that indicates you're in serious trouble. Right. And if it goes beyond that, a person needs a kidney transplant. Well, the misreading of that and the fact that it's falsely calibrated, or the algorithm doesn't really capture the information properly for African Americans. Mm-hmm. It does work to a limited degree on certain African populations. So if you go to West Africa, maybe Nigeria, it may get some very accurate readings, but it does not apply to African Americans, and it doesn't apply to all Africans either. So it varies, and it's not as sensitive a measure as people might want to think. So the problem is African Americans, because of how that's interpreted, are less likely to be recommended for kidney transplants. So, we wind up on the waiting list often if you can get on the list. But even if you're on the list, it's a long wait unless you can find somebody who's willing to donate to you, a private donor. Right. But it complicates our ability to get care. Basically people are written off. There's nothing that we can do for you at this point, but it's not based on sound evidence. It's based on this, mythology about what this means, what this marker means.
Right. So this, you're mentioning words that have become a part of everyday society as far as algorithms.
Yeah.
Sure. So where did the algorithm come from, and how does one create an algorithm? And who decided what the measurements were to decipher that this algorithm means this? Because it's every day in when we do Facebook, right. How we show up at the top of the list or with at the bottom of the list, and that's in a social media. But this is happening in our medicine.
Well, algorithms basically are a mathematical formula, and they're used quite frequently in medicine. They serve appropriate purposes. Often they're diagnostic tools in how they're used. For example, in flu season, there are diagnostic tools and algorithms that enable you to determine in the emergency room whether a person is coming in with pneumonia or the flu.
Cold. Okay.
Yeah.
Okay.
And that's important, obviously. Yeah. So with the flu, you might give them some, Theraflu or some kind of stuff like that, and they can go on about their pneumonia, and they can die. So you really need to make some clear distinctions about that. So it may help in many instances to differentiate one set of conditions from another. And keep in mind, when people present in the emergency room and go to the hospital, there's a lot of common symptoms. You know, you may have a headache, you may be have a temperature. Mm-hmm. How many things does that apply to? You know, you see what I'm saying? Diagnostics is very, very difficult process, and a lot of errors are made occasionally. Mm-hmm. People make errors in that process. So, these tools are aids to help doctors make the right decision. So, with the pneumonia flu thing, if a person presents with certain indications, a fever combined with this,
runny nose.
Yeah. You put this into a computer, and then you look at what it comes up with in terms of, well, this seems more like this, right?
Right.
Then you might run some tests to verify it, rather than take a person in and give them a whole host of tests all out the blue, which is expensive and usually not done. Maybe probably is not warranted. This way, well, I need to test them for this because this is what it appears to be. And so medicine is extremely complicated, as we are, as beings. And so these things can work to our advantage. But when they are racialized, that's another thing altogether.
Wow. I mean, so everything about our existence, the African American, has been racialized. I mean, everything about us, from our mentality to our physicality to our the structure of our inner workings. Our hearts are not as strong as somebody else's heart. Just a host of things, and now that it's all coming to the surface, which may be a good thing that COVID did, is to bring about the disparities, even though I think that there were some disparities that were already out there and known in the medical field. But just to a layman, maybe not so much, right?
Well, I want to put COVID-19 pandemic into perspective because, granted, a huge number of African Americans have died, and we have died disproportionately. So we are experiencing excess deaths from COVID. So if all things were equal, and that's not to say that white Americans are going to have any better outcome in this, but if our life expectancy and our access to healthcare, et cetera, was the same, then we would have the same life expectancy. Because we're the same people. This race thing is, like I said, absolute utter nonsense, right? So African Americans are dying prematurely and excessively from both infectious diseases like COVID-19, but more commonly every single day from chronic illnesses, the things that you mentioned about heart attacks, heart disease, cancers, kidney disease, etc. Now here's diabetes, huge killer in our community. But here's the thing that we need to really understand. So yes, COVID has killed tens of thousands of African Americans, no question about it. Right. However, over 200 African Americans die every single day prematurely. This was before COVID. This is going on while COVID is happening. This will continue after COVID unless there's some massive intervention. Not only was it going on before COVID, if we look back all the way to 1900, and that's about as far as we can gather real good information. Okay. And we total up all of the numbers of excess African American deaths from 1900 to 2021. Okay. We are seeing that death rate of 200 people a day all the way back for 120 years. Whoa. We're talking 9 million people, 7.7 million just in the 20th century. Okay. And the irony of this is in the 20th century, more African American women as a percentage of the Black population died than African American men. Okay. and a significant amount. We're talking about 10 and 15% more deaths of African American women than African American men, when the reverse was true in the white population in the 20th century. More men died than women. And you would think that would be the case under normal circumstances, even though, infant mortality, maternal mortality.
I was going to say the infant mortality.
But think about men who are more prone to violent deaths, more prone to accidents, et cetera, et cetera. And so the exact opposite happened in the 20th century for African American women than what happened for white women. All over the world, actually, all over the Western world, white women's life expectancy increased. And as you know today, they live longer than anyone. They live longer than white men and live longer than the other group. African American women live longer than African American men now. That was not the case in the mid 20th century. Okay.
Wow.
When we look back further than that, and we go back into the 19th century, the data is not there for us to have the same kind of evidence, mainly because the United States really didn't have a national system for collecting death data and had a national system for death certificates that all the states participated in until 1933. Okay. So even the first 3 decades of the 20th century is kind of a mixed bag in terms of data. When you go back.
So when someone died, they didn't have the reason, because when I did some ancestry research, it showed me why, like my great grandfather, what he died from. So they didn't have the cause of death back in the first 3 decades that medical.
They didn't have the cause of death in the first couple of centuries. And
okay.
partly because doctors, that's not particularly their concern why you die. They're trying to keep you alive, first of all.
Right.
And so in the early days also, the theory of medicine was completely different than what we have now. Now we have information about germs and bacteria and viruses. That was not known. So they had a different theory about what caused disease and what caused health, called the humoral theory. It goes all the way back to ancient Greece. This is what the medicine they practiced. What they believed was that there were fluid imbalances in the body that they called humors, black bile, yellow bile, etc., and that they had to be balanced to restore a person to health. The way they balanced them was through extreme treatments such as bloodletting and using things that would cause diarrhea and vomiting. The idea was to purge the person of those negative things and to restore health. So in the process, they killed more patients than they cured, including George Washington and a host of famous people. They were bled to death often because the doctors came and they said, okay, you're not feeling well. Let's take a couple of bits of blood out of you. And they do it repeatedly. And eventually the person is weakened to the point they die. So, okay. So they were not recording cause of death necessarily. When they did list things, they listed things that we consider to be symptoms, like fever, diarrhea. That's a mechanism which somebody may be weakened and they eventually die, but it's not the cause of their death, really.
Right.
For most, in most cases, just like today, if we said heart attack, heart failure,
right,
that's a mechanism. They may have had cancer, kidney disease, and maybe a host of other things, that cause it. But what happens when people die is their heart stops. So your heart's going to stop. You're going to stop breathing too.
Right.
That's what happens when.
That's what happens.
Fires, right. But that's not necessarily the trigger.
Right.
That causes that. That's the response to whatever else is going on, right?
Because it could be, for example, it could be high blood pressure.
Yes. It could be certainly hypertension. Okay. And yet the mechanism that actually transpires is that your heart stops beating.
Right.
So there was not really, really much notation of cause of death. And even now, let me say this. If you look at a modern death certificate, on the death certificate, it tells them how to fill it out in very great detail. It also tells them, look, if you can't figure it out, you need to have an autopsy to try to find what the cause is. Even with all that instruction, they're still erroneous. People still don't get it correctly. And there was a study done recently where they tested these doctors in this group. It was just like a focus group, and they only got 15% of the death certificate causes of death correct. And then they trained them, and then they got 85% correct. But when you think about it, when there are a couple of million people dying every year, if 15% of those are incorrect, then we don't know what caused their death. And it's important to know if there's something going on in our culture in terms of diet, nutrition, pollution, this is public health information.
The soil our food grows in, is it something
correct? Is there a new bacteria, a new virus? What's going on? What's caused it?
Right.
This is the point of collecting that information, is to do public health prevention and interventions when needed, to be able to monitor how people are doing and to correct problems, identify problems, and solve those problems. So, we're operating with one eye open and one eye closed.
I was going to say, we're operating at a deficit, sound like to me.
Lack of a better way of putting it, yeah.
Wow. But it's very interesting to me. And I guess I hope I'm intelligent enough to be able to have this conversation with you, because I majored in health and physical education.
All right.
And so I thought I was going to be a physical therapist. And I'm still entertaining that thought. I don't know why, but I am. And I did pretty good. I did kinesiology and human anatomy, made pretty good grades in my major. So when we talk about health, and I've been paying attention, I guess, since I've become a senior citizen. So I've watched both of my parents pass, my brother pass. And so I'm looking at what were the causes. I know some of the causes from my ancestors. So I'm paying attention. I pay attention to a lot of things that are different than what I used to pay attention to. So when you talked about the disparities the other day on the Zoom, it piqued my interest. I said, because see, this is something that we don't have someone of your intelligence to explain to us. When we go to the doctor, most people, I don't care what color they are, they just take the doctor's word for it.
True.
Okay, so when somebody can kind of break it down to you where you have some reasonable level of understanding of what's going on, that's like to say, just an example, I know that high blood pressure can bring about strokes. Some people don't understand that one has an effect on the other. And these are some things, I guess, especially in our community, that even in Louisville, the diabetes makes me crazy. When I moved back here, it was like, well, so-and-so's got that sugar. I said, you sound like it's something you're supposed to get.
Yeah.
No, it's not. So, and I understand that a lot of that comes from lifestyle. And lifestyle is your eating habits. I didn't eat a lot of, I moved out west. So my daddy used to say, I moved to the land of fruits and nuts, because everybody's trying to be healthy.
There you go.
Okay. So I didn't eat a lot of fried foods, so maybe that's why that didn't happen to me. But then when I come home and then I watch the lifestyle and the food that's consumed, and I'm saying, this is it, because we haven't had that lesson, to say that, you can talk about the Colonel is from Kentucky, but you really don't want to eat that chicken all the time like that. So
we have, I recognize what you mean by lifestyle, and I think that's part of it, but we have to be very careful to keep the context on this society and how, let me back up and say it this way.
Okay.
One of the key problems that causes these excess and premature deaths, one of the major factors in it, and in our incidence of kidney disease, heart disease, cancers, diabetes, is racial segregation. So racial segregation essentially redlines the Black community in many ways.
Right.
And by that, I'm not just talking about the financial redlining in terms of getting a mortgage and all that. I'm talking about access to healthcare, health education information, access to good, healthy foods with no grocery stores in the neighborhood. Segregated redline neighborhoods don't have grocery stores. They have liquor stores.
Right.
They have snack food places. That's what's going on. So, you know, that is a massive contributor to the problem that we have. When you add blue lining to that, that's the police surrounding and over policing our neighborhoods like we live in occupied territory.
Sure, yeah.
Financing their operations off of poor people through traffic fines and court fines and penalties on top of penalties and charges for parole and probation fees, et cetera, running their municipalities on the backs of poor people. All of these things in combination are tremendous stressors. And understand, disease is dis-ease. The chronic illnesses that we're talking about are related to the stressors that African Americans have to endure. And it is so extreme that what we see in African Americans, and particularly African American women, is a phenomenon called weathering, where a 20-year-old African American woman may have the metabolism and physiology of a 35 or 40-year-old woman because of these stressors that we're talking about, because of diet, lack of exercise, the kinds of challenges of just going through everyday life trying to survive. This is taking a huge toll on our community. When you add in the history of enslavement and Jim Crow, et cetera, there's something that we're now studying called epigenetics, which talks about the generational transfer of trauma from one generation
to the other. Yeah.
That's right.
Wow.
And understand, when we were born, we were already present in our grandmother's womb. Because when a female is born, infant is born, she has all the eggs she will ever have in her life. And so her children are already, whatever children she'll have, those eggs are already present in the grandmother's womb in that infant, right?
Okay.
I mean, it's in that developmental process, right? So essentially, what the grandmother is experiencing is going to be transmitted through her child to the grandchild to some degree.
Right.
Okay. Wow. So think about what was going on in the U.S. when your grandparents were alive. My mother came through the Great Depression, among other things. When my mother was 13 years old, 50 miles from where she was living in Florida was one of the worst lynchings in the United States history. A man named Claude Neal was lynched and tortured to death and cut up in pieces. They actually chartered buses of people to come and witness this in Florida. They accused him of raping a white girl, of course,
right,
with no proof or evidence or whatever. So anyway, I won't dwell on that. The point is, our grandparents endured tremendous
trauma.
My grandfather was in the war. My father was in the war. My uncle was in the war. I mean, so all these things are cumulative. And as I said, it's shocking to understand that you would have a 20 or 25-year-old woman who, for all intents and purposes, has aged to the point prematurely that she's in her 40s or thereabouts.
Yeah. Wow. That's amazing. That's unfathomable. Actually, someone's walking around thinking that they're young and fly and fresh, and really they are 10 years older than they appear to be.
Yes. And there's some clear, and let me be clear. I know these are really, really tough things, but I don't
No,
But
we have to talk. How many times have you heard this conversation
yeah,
on social media? Come
but
on,
but what I'm
not at all.
what I'm describing about the aging, which is called weathering,
Weather.
is actually measurable. We have in our chromosomes something called a telomere. It's at the end, the tip of the chromosomes, and
Okay.
telomere length is a marker of longevity or the lack thereof.
Okay.
And so what we see is these telomere lengths getting smaller and smaller prematurely, which is an indicator that this person's life expectancy is declining.
Right.
And keep in mind, African Americans live shorter have shorter life expectancy than white Americans. That's been the case in the past. It's changing though. White Americans' life expectancy is going down, and it has in the last couple of years. Primarily,
And ours is increasing.
no. They're just going. They're meeting us. They're coming down. And the reason why there's so many deaths attributed to opioid, there was a massive loss of life due to the opioid epidemic. It's still going on.
Right.
So there's that. It's interesting with the opioid epidemic. The media completely shifted in its treatment of drug addiction.
Tell me about it. Wait a minute, let me say this. I know where you're going. Because I used to say, I remember back in the day, especially in the 60s, when there were heroin addicts, there was an epidemic in this city.
Yeah.
And that people don't talk about. But it was prevalent in this community. Okay. Yeah. So, but then they went to prison. They sent them to methadone clinics. They did not treat it as if it was a disease and they needed treatment and they needed help.
Right.
So now that opioids come along, which is not the same thing, it's just in a pill form, so now it's treated differently that, they want to clear their records. They don't have any criminal records are banished. They're trying to help them get on their feet. They got programs for them so they can get living and get jobs. Man, they treated us like we were runaway slaves again.
Yeah.
So this was like this. We were with these animals, but this was, they were addictions and diseases that needed treatment.
Think about how they demeaned and denigrated people who were addicted to crack cocaine. I mean, they demonized crack addiction like it was the worst thing ever in the history of the world. They demonized children that were born to parents that were addicted, and said they would be damaged irreparably, which has never been true and has been demonstrated to be completely false. But here's what I was getting to, and you nailed it all. And the treatment that these individuals have received, what signaled to me what was happening with this. Early on, there was a newspaper article, New York Times article about opioid addiction in Vermont. And I'm reading through this. This is early in the process. And I'm reading through how sorry they were for these poor people in Vermont who who were living out in the rural areas, not bothering anybody, but fell upon hard times and somehow got addicted and blah, blah, blah. And that we need to show some empathy and sympathy and all this kind of stuff. So this has materialized into what the deaths that have occurred as a result of this opioid epidemic are called deaths of despair. So white folks are despairing. And that needs to be,
addressed,
emphasized, and that needs to be recognized by society. These are deaths of despair. These people need our help desperately. Whereas African Americans are junkies. They're drug addicts. They're felons. They're convicts.
Right.
I'm not hearing a lot of sympathy for deaths of despair in the Black community.
No.
Not even when they
never have heard of it and won't hear of it.
No. So this is the double standard that we're operating with, and it's tragic all the way around because none of the people who are the victims of these drugs, none of them should ever be in a criminalized situation. They should never be charged with a crime. These are health issues. They always have been health issues.
Health issues.
Yeah. Yeah, we don't see them treating alcoholics that way, even though alcoholism is worse than and most of these others. And certainly, we know from the drunk driving how deadly it is for the innocent people who encounter alcoholics on the road. So it's not something that anyone should have to be, subjected to, meaning criminal punishment.
Right. This I used to say, I used to look at that as well, that in the recidivism with incarceration, okay, and the number of incarcerations that have to deal with drugs in this, probably in most major cities.
Oh yeah.
That was, it seems to me that whole war on drug thing was just another way to contain, especially African American men, and now it's almost just as many African American women in the system. But it also has perpetuated itself, that it's not just, I mean, the father goes, then the son goes. It's like, and because the situations haven't changed much.
No.
You know what I'm saying? Nothing has been done to alleviate the problems. And so now here we are in 2021, that we're just touching the tip of the iceberg.
Yeah.
Can you believe that? Finally, we're really trying to address just what you're saying, that you have to do to dismantle a whole system of how medicine is taught and how it's used on society, just across the board, sounds like, but it really has had an effect on us.
Well, I teach and preach.
Teach and preach.
That medical professionals and the medical establishment has a special obligation and responsibility, not just for dismantling racism in medicine, but in the society that we live in, because doctors invented scientific racism. Right. Where else could it come from?
So
who else knows?
This part of when the AMA came out and said that now racism is a health crisis.
Mm-hmm. Yeah.
Wow. It took them a long time to figure that one out, huh?
Oh, it took them all the way up until just this past year. And not only that, there's many members in there kicking and screaming who oppose that. But let's be clear, the AMA was founded in the middle of slavery in 1836.
Sure. All of it. All these, what they say, all these isms, these systems that we have, even now that we're talking about the medical part of it, and then we look at the educational part, that they don't, this critical theory,
critical race theory.
Critical race theory. So now they're going to tell, I want to write a piece on it. Sometimes I write music, right? And I want to write a piece, John, that says, but it happened. We didn't get on a boat going to Sandals. Yeah. Somebody intentionally, everything that happened has been intentional. And we did not intentionally get on a boat, or we did not intentionally leave our tribes and our homes and our royalty and our wealth that from the land where we were birthed to come over here. We didn't come on the cruise. We weren't on the Princess.
That's true.
You know what I'm saying? We thought we were going on a Carnival cruise line, but it happened. All of these things that they want to say didn't, but they happened. Yeah. So you cannot. How can you refute that just because you say, I used to say, because when this other fellow was in the White House, just because you say it don't make it so.
Yeah. Well, our whole history has been trying to find out who we are and what's happened to us, and how to get out of these circumstances that we're in today. And we cannot actually navigate our way out without understanding how we arrived here.
Right.
You know, our history is vital for our survival. And I'll give you an example. We chatted before the show, and you asked me about my name, Chenault,
Right.
and I indicated it has long Kentucky roots. Um, the earliest ancestor that I can name, earliest African ancestor that I can name, was born in Kentucky in 1790. Now,
Wow.
she indicates her parents were born here too.
Okay.
Means they were probably here, 1770s thereabouts.
Okay.
So her name was Miranda Rhodes, Rhodes. Miranda Rhodes was enslaved for 75 years. She was freed in 1865. She was enslaved for 70 years. I'm sorry.
Mm-hmm.
And she lived another 15 years after that.
Mm-hmm.
But I spend quite a bit of time thinking about her. I think about her all the time. My thoughts go to, well, two things. One, I cannot imagine 65 years enslaved. It's just incomprehensible to me. And the second thing that I think about all the time is I better damn well do my work, because Miranda Rhodes went through 70 years of bondage
Right.
for me to be here.
Absolutely.
She wasn't joking. Her survival was for a purpose. And not only am I her descendant, one of her grandchildren served in the Civil War here in Kentucky. His name was David Rhodes. Okay. So, we owe everything to our ancestors and to their struggles. And that's why we need to know our history, because we owe them.
We owe them.
We owe them.
Absolutely.
And we need to know that debt so we can pay that debt. So I know that debt. And I told a friend recently, I said, the flowers that I want to place on her grave and on as a memorial to all of my other enslaved ancestors, and those who had to endure Jim Crow, American apartheid as well, is my work.
Yes. That's your gift. That's your repayment.
That's correct.
And that's a wonderful thing. That's why I was intrigued, and I wanted to know more. I said, if nobody else is listening, I don't even care, because he's going to tell me some stuff that I do not know. And I want to know. And I want to thank you for coming on the show. And we're going to do this again.
We need to, because what you don't know is that I'm a musician and composer, and that I have written an opera. I've written for jazz band, chamber ensemble, orchestra, and I had the great honor and privilege of working with Cleo Lane, one of the greatest jazz singers.
Oh, I know.
In the history.
Cleo, contralto.
Yes, Cleo is a dream. She's not doing well, unfortunately, but I had the opportunity to work with her on 2 occasions. So we have to talk music sometime.
Yes, we're going to talk. Look, you saw my ears pop up. What? So just hang on for a minute. I got a couple of things I want to tell my audience, and then I want to say something to you. Okay? Hold on. Sure. Mr. John Chenault, Associate Professor out at U of L. Did you hear that? Did you hear that what he is tasked to do is to somewhat dismantle how the structure of medicine and how they treat us, so we can deal with, maybe they can understand how to get to some of the disparities, or try to stop some of these disparities. That's some deep stuff. I don't know. Y'all better pay attention. We better wake up. Spike Lee did the movie years ago, but we still need to wake up. We need to pay attention to a lot of things that concern us. Just like he said, it's we have to know where we come from. We have to know our history. We have to stand up and account for our existence. because our existence is through the existence of someone else that survived to a certain point that made our lives possible. You got to come on, you got to face that. You have to have an understanding about that. You have to teach your children that. Your children need to know all about their relatives, all about their ancestors, where they come from, what region they come from. You need to know stories, because that's what the African culture is full of stories. And that's how we passed on our culture. So we had Juneteenth the other day. I wasn't here. I know y'all had a glorious time. But all the excitement and the programs that went on, I wonder if we make sure that we touched on how we got here and what we have to do to stay here. Because every day somebody is trying to take every right for every social norm, whatever we have in this society. They're trying to take that away from us. So if you want to know why they're out in the streets protesting, because they have to. They need to. We must. I'm going to switch gears. I've had the privilege this week. I just was on Wave 3 to talk about a relative of mine that passed away. And she was one of the first African-American school teachers over in Jeff. So if you can imagine an African-American school teacher in Jeffersonville's Indiana, so that's a Hoosier state now, so come on. That this woman, my Aunt Margaret Hammond, I found out more about her in her passing than I did during her lifetime, which is it was no fault of anybody's. I mean, I didn't live in Louisville. We both born and raised in Louisville, but I went away, she stayed. Just retired from teaching school after 34 years. She evidently had an effect on most of all of her students. If you see her Facebook page, she was adored and loved. She has a posse of teachers that were around her that held vigil while she was in hospice. And I got to see the sisterhood and the love. And not one of them was Black. Not one of them was Black, but it didn't matter because that was her family. That was a family she chose. And that was a family that was there for her, that was continuing to love her and show her the love. And so tomorrow we are going to have a memorial. I'm calling it the last graduation. She was able to print up the programs for preschool graduation the 26th of May. That was the 2 weeks that she had. She was up and out and about before she declined. And so I'm calling this the last graduation, but it's going to be a celebration. So if you knew Margaret Hammond, we invite you to come out over to Southeast Christian Church in Jeffersonville, not in Louisville, in Jeffersonville, tomorrow at 3 p.m. That's my auntie. Everybody called her auntie. She loved children. You could call her auntie because she was full of love. So I just wanted to pay homage to my Aunt Margaret Ann Hammond. She was my daddy's baby sister. So that's tomorrow at Southeast Christian Church. And on that note, it's dinner time. Guess who's coming to dinner? Bon appetit. I'll see you on Monday. Take care. Ciao.